Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by Takeda. A few weeks ago, a new hypoglossal nerve stimulator was FDA cleared for the treatment of obstructive sleep apnea. This will bring us to 3 options to offer our patients. Are they all the same? Are they all meant for the same patient population? What about efficacy? Is there one procedure that is less risky? Dr. David Kent is an associate professor and director of sleep surgery in the Department of Otolaryngology, Head and Neck Surgery at Vanderbilt University Medical Center. His research explores the neurophysiology of the upper airway with a particular focus on mechanisms for control of breathing in obstructive sleep apnea and their application towards novel OSA treatments. He has been heavily involved with implanted device-based treatment of obstructive sleep apnea and is here to help us distinguish between the various devices and how to tailor hypoglossal nerve stimulation to our patients. By way of full disclosure, he has been a consultant for Inspire in the past and is currently a consultant for Nyxoah. Welcome. Glad you could be here today.
Thanks, Seema. Very happy to be here with you.
So I wonder if you can sort of take me back a little bit and tell me about the whole premise of hypoglossal nerve stimulation and why it works to treat obstructive sleep apnea.
I'm certain. It actually goes back quite a bit. There were animal experiments. Actually, the first series of experiments were in Japan in the 80s. Look at stimulating the hypoglossal nerve to activate the genioglossus muscle, which moves the tongue forward in dogs, which translated in the 90s to animal experiments here in the US that then eventually became, in the early 2000s, the first feasibility trials that ultimately then became the first FDA approves implantable hypoglossal nerve stimulator in 2014, which was the Inspire device.
I had no idea that started in the 80s. Wow.
Yeah, there's a long history of this physiology work. And I think to some degree it maybe was not a high focus area for a long time. And I think only in more recent years have, well, frankly, the investor and industry side of medical care in the U.S. recognized what a large, needful population there is in this space.
Oh, that totally makes sense. So Inspire from 2014 isn't the same as it is now, right? Like, hasn't it evolved?
Yeah, we are now on the, if I get my math correctly, correct, depending on what you want to count as a new version of the device or not. We're basically now in the 3rd generation of device since FDA approval
Okay.
in 2014, which is termed the Inspire 5 device. So it was actually the Inspire 3 that came to market.
Oh, that's interesting. I didn't realize that. Okay. So what's the current process for implantation? What's involved?
So involves a consultation with a surgeon who's experienced in this space. The care pathways getting to that surgeon can vary a little bit. Some surgeons work directly with a sleep medicine professional. Some surgeons are also sleep medicine physicians, and others see patients who come in from the community and then are in turn referred to sleep medicine. But in my own personal opinion, in sort of the optimal setup, there's a shared decision making where both somebody with expertise in sleep and somebody with expertise in upper airway anatomy and surgery evaluate the patient and think, yeah, this person could potentially be a good candidate. That involves a series of several criteria, but the sort of main things are that the patient has moderate to severe sleep apnea, that they have a documented history of either struggling with or failing to respond to CPAP therapy or an unacceptance of it. And then they're anatomically appropriate for the existing therapies on the market. That is essentially this lack of complete circumferential palatal collapse, which is ascertained during a sedated diagnostic procedure called a drug-induced sleep endoscopy. But to my mind, what that really translates to is that they have a moderately or not terribly collapsible airway.
Mm.
The more collapsible the upper airway becomes, the less likely patients are to respond to these forms of therapies.
I mean, that makes sense. So, talk to me about Genio.
So the Genio device is now the second FDA approved hypoglossal nerve stimulation therapy to market. They've actually been around for over a decade as well in
Oh, no way.
development.
Okay.
Yeah, yeah. Their approach to therapy is a little is different from that
Okay.
of Inspire device. Both of them target the same portion of the hypoglossal nerve and are designed to capture the nerve branches that uh, activate muscles, primarily the genioglossus muscle that protrudes the tongue, that moves the tongue forward while avoiding robust or ideally any activation of muscles that pull the tongue back into the mouth, primarily the hypoglossus muscle and the styoglossus muscle. And so the surgeon's job in the operating room is to make sure they are placing the device du jour on the appropriate part of the nerve. Now, how the devices differ from one another is in a couple respects.
Okay.
Um, the Inspire device is a unilateral hypoglossal nerve stimulator. So it's on one of the two hypoglossal nerves, typically the right one. And it is powered by an implantable pulse generator. So there is a small thin wire connecting it to a small battery and computer that live under the skin on the chest wall. And so there's no external component to the therapy. That battery is not rechargeable.
Mm.
That's the sort of there are pros and cons to making a battery rechargeable in the medical device space. And so it's good typically for in the range of quoted about 8 to 11 years. So when I'm talking to patients, I say about a decade.
Mm.
And then the battery does need to be replaced. The Genio device has no implanted battery. So there is one incision to place it instead of two, and it sits in the midline, and so it's actually on both the left and the right hypoglossal nerve. So it's a bilateral hypoglossal nerve stimulator, and it's because there's no implanted power source. It does still have to be powered, and so the patient has to wear an external power source overnight that is placed under the chin with a sticker and adhesive, and then they remove that sticker in the morning, and the little what's called the activation chip, which is the external power source, has to be then recharged again and is placed back on the charger.
So, are there other differences, right? So, this one is bilateral instead of unilateral. Um, but there's no respiratory sensor, right, for Genio?
It's true. And so Inspire's therapy for many years used an actual pressure sensor that was implanted between the intercostal muscles of the rib cage and um synchronize the device
Yeah.
to the respiratory cycle. Ideally, when the signal was clean and everything was looking good, ideally would activate the therapy right sort of towards the end of expiration in order to essentially prop or pop the airway open prior to the next inspiratory breath. We are trying to prevent airway collapse
Mm.
in an ideal situation, not to have to pop it open once it is suctioned closed, because that takes a lot more energy.
Yeah, yeah.
Um, the Genio device, you're correct, is open loop. There is no direct measurement of respiratory effort. In fact, instead, the device is programmed to a duty cycle, and that duty cycle is designed to overlap as optimally as possible a patient's own respiratory cycle. And so, yes, it is open loop, but that can be configured or customized, say in the sleep laboratory.
Okay, so that's interesting. So, Inspire is more synchronized to respirations, and Genio is sort of time based.
That is correct. Now,
Okay.
there's, I think, a couple sort of important components about
Yeah.
that. Synchronized certainly immediately sounds to one to sound, better, more
Yeah, yeah, yeah.
physiologic, and I would agree that yeah, in practice it is a good idea. There are times where that sensing component can work really well, and times in the past where the sensing data has been pretty noisy, and so the device will basically fall back to sort of a backup rate
Oh.
if it's having trouble actually pacing an individual respiration. Now, with the advent of the Inspire 5 device, which is the one that's come to market here within the last year, um, that device has no external pressure sensor anymore. It's all
Mm.
moved to an accelerometry based strategy that is inside the IPG. And so, in my own just personal experience, just looking at the data off that device, it does look in general sort of cleaner than some of the artifact that we would see off the respiratory sensor.
Interesting.
Um, but then the way the therapies work is that they are designed to, it, the airway has phasic vulnerability to collapse. And so the airway is most vulnerable to collapse, in particular at the end of expiration. There are
Mm.
two things happening there that predispose that situation. Three, really. One is that is when the airway is actually at its most hypotonic. So there
Mm.
are actually phasic variations in upper airway muscle motor tone throughout just the cycles of the respiratory cycle. Two is that the airway is actually at its smallest cross section at that point, and so by definition, it's going to also be at its highest resistance, and so you are at greater risk of setting up an obstructive site and a pressure gradient within the upper airway if you were to immediately start breathing in aggressively at that point. And the third is that we're at our lowest lung volumes in the respiratory cycle at that point. And there are data to suggest that functional residual capacity and expiratory lung pressure actually plays a role in stabilizing the upper airway. The mechanisms behind that are not fully elucidated, but put all that stuff together and you're most vulnerable right at the end of the breath, right before you go to take that next breath in. In fact, in some people who have very collapsible airways, their airway may be fully collapsed. They may be
Mm.
technically apneic with air trapping in the lungs at the end of expiration because the closing or collapsing pressure of the airway is higher than the pressure gradient that's still being generated from the lungs. All that being said, if we can pop the airway open and really improve that cross-sectional area before the inspiration begins, ostensibly, if you can decrease the intensity of your stimulation,
Mm.
and you can perhaps shorten the stimulation phase to really just capture when that breath is coming in, and you could therefore have perhaps, let's say, a less aggressive therapy. Any chronic medical neurostimulation therapy can't just be always on.
Yeah, that's fair.
It's actually toxic to the nerve target, and you could feasibly cause depolarization injuries, et cetera, over time. And so that's why all these therapies work in an on-off fashion instead of just being on all night.
Yeah.
And so that being said, no one has actually demonstrated definitively yet that one approach is optimal versus the other. There just isn't really the data out there to say, oh yeah, absolutely. This one synchronizes really well to respiration and it does such a better job of opening the airway. This one is on a duty cycle and it is either just as good or it's not as good for whatever particular reason. We don't have those data.
Mm.
There are scant publications that say if you stimulate at the totally wrong part of the respiratory cycle, like just during expiration, yeah,
Yeah.
you don't get a very good improvement in your inspiratory airflow. But that's a little different than the sort of nuance we're talking here. So I would say that both therapies make arguments about sort of who's got kind of a more optimal approach. One is, you know, simplicity of hardware. The other is potentially more physiologically appropriate. But I think from a data standpoint, to my mind, the jury's still out as to whether one is optimal versus the other.
Well, it's funny. I hear you say pop open the airway, and then I also hear you say sort of prop it open because you want to avoid that collapse. It kind of takes me back to residency where our pulmonary attending would always tell us that like the lungs are kind of like a balloon, right? Like it takes that first little bit is really hard to blow and then whew, right, it just opens. and it takes a lot less effort to keep blowing the balloon once you've sort of started that whole process. So that's kind of what you're taking me back. You're taking me back to that. And so what I'm kind of wondering is, so we've kind of talked about one synchronized, one isn't. And then what I think I'm hearing you say is we're not even sure if the synchronization matters.
Yeah, that's exactly it. It
Okay.
may well, it may not. We just don't know yet.
And so I think the thing I find really very cool is that for the Genio, the battery is external and rechargeable. So I heard you say the IPG's implanted pulse generator. Is that what that means?
That's exactly right.
Yeah. Okay.
Yes.
And so that you have to swap out every 10 years, give or take, right?
Hmm.
So then you stick the sticker on under your chin and you stick the activation chip on that, right? And then does it like Bluetooth to your phone? Like how does that work?
Yeah. So the device actually has an well, so let me back up. The
Yeah.
device has an app for programming, say changing power settings.
Okay.
That is a phone-based app. But what actually activates it is removing it from the bedside charger. And so
Oh,
and so
okay.
just like the Inspire therapy uses a remote control that you use to activate the therapy, and once you activate it, that starts a start timer that is designed to allow the patient to fall asleep prior to therapy, actually activation and muscle activation. In the same way, that timer is started with the geniotherapy by removing it from the charger overnight. So, in fact, if a patient wakes up overnight, they want to use the restroom, they need a break just to be able to fall back asleep, etc. This current approach with the therapy is you pop it off the little sticker for a second, set it back on the charger, that re-clicks it, resets it, and
Okay.
you can reapply it.
Does it click into the sticker? Is it like a magnet? Like how does it stay on?
There's like a small, it's a small sort of little physical button. It's like a snap that you
Oh
would
no way.
use on a piece of clothing. Yeah.
Huh. So what happens if your phone dies?
Well, the nice thing about the therapy is that it is all sort of the primary functions, turning it on, turning it off, are um, based entirely whether it's on you or on the charger. So
Okay.
on any given night, you don't require the phone app in order to be able to interact with it.
Oh, okay. Okay.
Right. If you want to change a programming parameter, like just as the Inspire device has a remote control that allows you to change the intensity of stimulation, change the amplitude of therapy, the remote control or excuse me, the application for Nyxoah
Hmm.
that's on the Genio device that's on your phone similarly gives that level of patient control, and that can be changed with the app. And so, yeah, if your phone was dead in the moment, you might not be able to change a power level, but I think you get it plugged in using probably the same power cable that you could use for your charger overnight. You could reestablish
Okay.
contact for that moment.
So, okay, I remember when we were prepping for this, you were trying to explain that it works like a cochlear implant. And so my like mea culpa, I'm a pulmonologist, like I have no idea how a cochlear implant works.
Yeah. So it's radio frequency energy, what's called sort of induction energy. And I am not an engineer. I'm going to say
Mm.
that now. So all I know is that it's the electro portion of electromagnetic radiation. And
Oh, no
so
way. Okay.
you put two coils in close proximity to one another, just very much like transmitting radio energy from a transmitter to a receiver. There's the energy in that signal. And so that is recruited or received by the receiver coil. And so the activation chip of the geniotherapy transmits this energy within a very clear range. This thing won't work if it's setting on the nightstand. It has to be within essentially just a couple centimeters of the receiver coil in direct alignment with it under the chin on the sticker,
Huh.
and it transmits this very low amount of energy. It's very safe to transmit through the skin. We've been doing this for decades in the cochlear implant world, and it's received by what's called the implanted or the internal stimulator, which is the antenna of the Genio device, the actual implanted portion that's what delivers the energy to the hypoglossal nerves. But that really is just in its current iteration, at least, it's a piece of hardware.
Okay.
To way oversimplify it, it's a literal antenna that receives and splits this energy signal. All of the brains of the therapy, what's controlling the amplitude and the pulse duration and the pulse width and timers and all that kind of stuff is the external component, uh,
Huh.
which yeah.
So the thing for a cochlear implant that you see, is that the battery?
Yeah, on the outside, it's
Huh.
essentially the brain of the whole device.
That
What
is
is
really
doing
cool.
Yeah, what's doing all the audio processing, from the outside world. I mean, these things have Bluetooth connections inside them now. People literally use them as Bluetooth headphones.
No way.
Yeah, yeah,
That's
yeah.
awesome.
Yeah, when they go see the audiologist and their whole spectral profiles reprogrammed, etc. That's all involving the outer component that transmits the data to the internal receiver.
That is cool. So then Genio, is it MRI friendly?
It is both these devices are what are called conditionally safe for MRI. That
Okay.
means that using certain MRI parameters, they are considered safe and won't cause injury inside an MRI machine. And so um, the Genio device has been approved, is conditionally safe rather, for both 1.5 and 3 Tesla magnets, which covers very well the whole, really what you see in normal clinical care in terms of MRI strength.
Okay.
Inspire has been conditionally safe with MRI for many years at 1.5 Tesla. And
Okay.
I believe that they are seeking or have acquired 3 Tesla conditional safety as well.
Mm,
I haven't personally yet seen any official documentation of that, but if it isn't already granted, then I do
mm.
believe it's in the works.
And so if you explant it though, then that wire is not MRI compatible, right?
So there are very specific test scenarios there. So
Okay.
what happens is they run a bunch of simulations and actual testing for these sorts of things, and the math of whatever goes on in determining MRI safety goes far beyond my own understanding. But there are basically certain scenarios where they've looked at the device and they said, yeah, that's okay for MRI.
Okay.
And so, for instance, with the Inspire therapy, they have established that the MRI conditionality, the safety, persists if the entire um, now old or out of date, let's call it, external respiratory sensor component is left intact inside the body, as long as there are not any, breakages in that lead or current leaks or anything like that. It's safe. Um, the stimulation lead can be left in place, the essentially the last 9 centimeters of it. And
Okay.
so that there's a small anchor. If you look at x-rays of the Inspire therapy, there's a little anchor that sits on the tendon to the digastric muscle that is sort of a strain relief anchor. And then 9 centimeters down that lead is the actual cuff that is on the hypoglossal nerve. And if it is trimmed right at that anchor, that residual 9 centimeters is also considered to be conditionally safe. Now,
Huh.
you might be in a setting where and a lead is actually broken. Um,
Mm-hmm.
and you do your best to remove it, but there's a portion of the lead that's left behind, and up to a 2 centimeter fragment of bare wire is permissible as well in terms
Whoa.
of maintaining MRI conditionality.
Is
So,
it really? That
uh,
surprises me.
yeah, so very specific sort of scenarios, and for any um, listener on the show, I am not a lawyer, and don't take this as gospel for how to, what you can leave behind. But those are the broad strokes.
So let's take a short break, and when we come back, we'll talk more about hypoglossal nerve stimulation. You're listening to Talking Sleep from the American Academy of Sleep Medicine. Welcome back to Talking Sleep. We're talking with Dr. David Kent about hypoglossal nerve stimulation. So let me ask you this. Is bilateral hypoglossal nerve stimulation better than unilateral stimulation?
Sounds like it should be, doesn't it?
Kind of.
You think, yeah, if one is good, two is better, right? I mean, that's the way the math usually works. I'm going to say the jury's still out. If you
Okay.
look at the DREAM study, which is the pivotal trial for the Genio device that was published last year, the data are interesting. It was a trial that was conducted during a challenging time. It opened, I think, February of 2020, just when obviously the COVID-19 pandemic was sort of racing around the world. And there is a very real loss to follow up in
Mm,
over the course of that pivotal study. Just kind of hand wavy the numbers. They dropped from around about 115 patients or so implanted down to about 80 or so finishing the study. I don't have the numbers immediately in front of me, but those are the sort of ballpark numbers. And um, the the Inspire trial that was published in 2014, the STAR trial, really impressive, like really well conducted. Something like I think 124 of those 126 patients completed the trial. Really great retention, far better than you see in a lot of device trials. And so that loss to follow up, you don't have a final endpoint for those patients. And how you evaluate them statistically is very important because it can very much influence your
yeah.
results. For instance, one kind of trial design that was not used is, oh, we'll just take the last sleep study that they had and we'll just impute that at 12 months and pretend like, well, that's what we got.
Mm.
Um, and that is not what was done here. So conservatively,
Yeah.
when you look at this responder criteria, um, investors love responder criteria because it's a binary outcome. It's black
Yeah.
and white, right? You
Yeah.
know what you got. You either won the day or you didn't. And so the share criteria, which have been used in the sleep surgery space for decades now, are imperfect, I think, is at best. But essentially, it's decreasing the apnea hypopnea index by at least 50% and bringing the patient down below an AHI of 20, which is our old historical threshold for moderate sleep apnea to mild sleep apnea. And so in the trial, in the STAR trial, about 2/3 of patients were share criteria responders. Of all those had finished. And in the DREAM trial, about 2/3 of patients that were evaluated at the end of the study also
Mm.
were responders to therapy. Now, all those people who didn't finish the study, they were treated as non-responders.
Mm.
And so we've got a bunch of people where we actually have, let's call it censored or absent missing data, and they were all treated as non-responders to the therapy, which means, well, there must have been, what does that mean for the people that did finish the study per
Right.
protocol?
Yeah.
The responder rate in that group was a bit over 80%, which is
Huh.
a materially different number, but you have to look at it through the lens of, well, maybe it's only people who were doing well with the therapy that were the ones who stuck around for the trial. It's a
Right.
very valid and important criticism. So when I look at these data, I try to take it at sort of its most conservative and say, nope, let's use the everybody, finishing the study marker and say about 2/3. And in that setting, you can squint your eyes and maybe sort of see a little differences in the shades of gray. But when it comes down to me looking at those data, I say these look like largely equivalent therapies in
Mm.
the currently available data. Understanding we have had a much longer ramp to evaluate Inspire therapy, see how it works in the sort of the real clinical world, et cetera, when we're outside the boundaries of a very carefully controlled clinical trial. The Genio therapy will have its own um, race to run in terms of demonstrating whether or not it is efficacious in the real world. But when I have a conversation with my patients about these therapies,
Yeah.
I say on paper right now with the data that we have available, they look to be largely equivalent. And your choice is really more a matter of form factor preference at the current time until I have data to say, one is better than another in terms of synchronization to respiration or bilateral versus unilateral, etc.
So, can I ask you something? When I read the paper on Genio, I thought it said that complete concentric collapse wasn't a contraindication. But then in the paper, it also said that the people with complete concentric collapse were excluded. So initially, I was like, oh, okay, this will be great for the people who don't meet the criteria for Inspire. But then they were excluded in the trial. Like, help me reconcile this.
Yeah. Um, I'm not immediately sure. I was on the paper writing committee, so if we wrote something that made you think that the CCC patients were in the trial, then I did a
No, no,
bad
they
job writing.
weren't.
I did a
No,
bad job writing the paper
no, no,
because
no.
no, they weren't.
No, they weren't. They
No,
weren't.
I
But
know.
that it wasn't a
Right.
contraindication. So, like the trial, they were excluded. But then in some of the other paper, it said that it wasn't a contraindication of Genio.
So I think we'll need to go back and look at that together because
Okay.
the current setup of that trial is that yes, those individuals they went through a screening, drug-induced sleep endoscopy. It was adjudicated by a core reviewer, and individuals for whom the core reviewer determined there was complete concentric collapse were excluded from implant, so they did not receive it. Now, the sort of nuance that does exist is in the FDA labeling
Yes.
for the therapy.
Yes.
Complete concentric collapse is there's a warning on it, but not a direct contraindication. So there do seem to be some individuals out there who have gotten the impression that the therapy is a treatment for complete circumferential palatal collapse.
Yeah.
Now, while the sponsor, the company, Nyxoah, is currently running a study called the Access trial, evaluating just that question: how well do patients with complete circumferential collapse respond to therapy? I have personally not seen any data from that trial yet, and so can't speak to whether or not it actually works or not.
Okay, so that's what got me because I read the FDA indication and I was like, oh, well, that's kind of cool. But then it didn't fit with the dream trial. Okay, so that's helpful. Thank you. Um, so then does it matter? Like if they think that it isn't, and I guess maybe you're telling me it does matter because that wasn't part of the trial.
Yeah, I mean, they weren't studied, right? They're being studied now in a
Yeah.
separate study. Yeah, the challenging thing, Seema, to get on a tiny soapbox for just a minute,
Yeah.
is that the
Feel
data
free.
for complete concentric collapse come from a 2012 feasibility study where about 7 patients at one center were identified as having complete concentric collapse and were non-responders to therapy in a retrospective analysis.
Okay. 7.
Yeah, so
Okay.
like three of those patients did not have CCC and they were responders to therapy, and 4 of them did have it and they were non-responders to therapy. Or maybe the 3 and 4 is the other way. I don't remember exactly.
But almost split.
But based on those data,
Yeah.
complete concentric collapse has been excluded for all of the tens of thousands of people that have
No
received therapy
way.
since. Yeah, and CCC is it's a it's an endoscopic finding. There is
Mm-hmm.
ultimately a subjective component of the assessment, even in the most well-intentioned surgeon. And
Yeah.
so there's always going to be some disagreement in, is that CCC? Is this CCC? And I think more important is that I think that there are probably very different underlying physiologic drivers of why one airway may look that way versus another. And some of those probably respond very well to these sorts of therapies and others probably don't. And we haven't figured all that out yet.
Well, that's what I'm glad to hear you say that it's subjective because, when I look at it, because I mean, I'm a pulmonologist, right? Like, I don't do these. And we have a bigger center in our city and they do all the Inspire. So when somebody will pop up a video during a talk and they'll say, oh, look at this. This is clearly this type of collapse, right? And I'm always just like, is it? Like, I can't tell. What is that? What's falling? Like, how do you tell when it all meets in the middle?
Yeah. So drug-induced sleep endoscopy it's a it's an interesting diagnostic approach to things. It's technique dependent, and so
Okay.
the depth of sedation matters.
Mm-hmm.
There are published data that suggest that individuals' patterns of airway collapse actually change over the course of a sedated examination. Um,
Huh.
yeah.
Because
And
the sedation wears off or what?
no, it very well may be just that, we're not static robots, and the
Huh.
underlying drivers of one pattern of collapse may shift in a single person as their neurologic state changes, as the muscle responsiveness and tone of the upper airway changes, fluid shifts overnight if you're looking at this on a longer scale.
Huh.
Um, just like somebody doesn't snore at the exact same volume, tone, pitch, amplitude, whatever, all
Yeah.
through the course of a night. In the same, that is your external signal that actually that person's airway is very dynamically changing state
Oh,
over the
that
course of the
is
night.
what a good point.
And so those exams again they're a snapshot in time with the
Mm,
sedated exam where your sedation agent itself affects what you might see in the airway, where how aggressively you've sedated someone matters, where um, a whole host of things come into play. Their head and neck position itself can
mm,
influence how it looks in the OR. And so um, I think it's less about drug-induced sleep endoscopy having limitations. It does. I think even proponents of it will have to, acquiesce that yes, there are limitations. But I think what that really speaks to is the complexity of the disease, right? And
mm,
that's just the anatomic side. And then we've got all sorts of interesting research looking at the non-anatomic drivers of obstructive sleep apnea. So I think
right.
there's plenty to keep people here busy for years to come.
So it's funny because then that like this is a way more complex conversation, right? And I know sort of sitting on the sleep side of it and not the ENT side of it, I know that I kind of joke, right? We joke with our friends about I feel like we spend like 5 or 10 minutes at the beginning of a visit for Inspire kind of deprogramming people. Like they have these really high expectations. I want that hoseless CPAP. And then when you kind of get into what that actually means, like almost universally, they're like, oh, I didn't know that's what that was. Is that where you are too?
It happens for sure. And so, direct consumer marketing, which is available here in the US, I think is a double-edged sword.
Mm-hmm.
It helps people who may have otherwise never heard of a therapy alternative or option that could work for them to be made aware of it. But, advertising comes in short little bits, and we have short little attention spans. And so I don't think that it is appropriate to to suggest that a company is entirely responsible for educating a patient on what their therapy is.
Uh-huh.
Um, so I certainly spend my time deprogramming patients as well, and I think even that an organization like Inspire has modified some of their marketing over the years, listening
Mm.
to feedback from physicians, from sleep physicians and surgeons. There was a time when I had patients coming in the door saying, "Yeah, I'm here for Inspire," not understanding that there was surgery involved that
Oh
day.
no. Oh no.
Yeah, yeah, it's a little better than that. And I think I don't. Perhaps maybe the consumer has become more savvy. I think in general people show up having done a bit more research than there was in the early days. I think there's probably just more material out there now. Um, but yeah, at the end of the day, it is our job, I think, not just to, you know, evaluate whether a candidate checks off the boxes, but whether they really are, putting it all together really appropriate for that therapy. I've had so many patients walk in the door where, they got the opposite end of the stick at the other end of the spectrum with the sleep lab. Somebody titrated them to 25 over 20 when they've got
Ay.
a BMI as 23, and it's blast off with a rocket ship every night.
Yeah, 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 yeah.
And so I think there are probably things that could be changed about our care pathways on both sides of the spectrum to get people where they need to be, you know, without losing them. I think that's always our big concern
Yeah.
on the surgery side, is that I think that there are patients that come in and have, unfortunately, maybe a bad CPAP experience out of the gate. And instead of being counseled on alternatives, coached on that sort of thing, et cetera, where they could be a candidate, they're they fall out of the system. And
Yeah, agreed. Yeah.
those are the ones I feel bad for.
Yeah, I agree. And I think that's it's such an important message, right? That like it doesn't necessarily matter how we treat it. It's just important that we treat it. And what that treatment looks like is going to change. And maybe you do like a dental device when you travel and a CPAP at home, or maybe you do Inspire, or maybe you do, something else. I think what I've heard from some of my colleagues who are involved in doing Inspire is that now with tirzepatide, their patients are losing all this weight and then their sleep apnea goes away. So, what do you do with the device?
Mm, really important question. Um, you do whatever the patient wants.
Mm,
So I think that this is a very active area of clinical investigation. And my own personal take on it is to be conservative upfront
yeah.
and to be conservative on the back end as well. And so that happens in sort of two primary ways. One is that if a patient's willing to consider these new medical therapies and they look like they're a good candidate for tirzepatide. I mean, look, I get people in the door of a BMI of 24. That guy's tirzepatide is not going to get that guy anywhere, right?
Yeah, yeah,
But
yeah, yeah.
um, people are good candidates for it who can get access to it, all those sorts of things. I am a proponent of it, and I think there was a lot of hand wringing in our field, perhaps less on the medical side and more on the investor side about, surgical therapies are gone now. And
Oh, yeah, yeah.
but when you look at the demographics of moderate to severe sleep
Yep.
apnea, over 50% of people with a BMI over 40 have moderate to severe OSA, and I can't effectively treat those people with surgery right now,
Yeah,
right?
that's fair.
50% of the people in the Zepbound trial, give or take, still had moderate severe residual disease. Those people need something else.
Mm-hmm.
So I see this as a tool to help customize care and perhaps get a good cohort of patients who otherwise couldn't do it into an appropriate treatment range. On the other end of that conservative spectrum, I'm conservative about taking it out with patients in that there are a lot of emerging data that suggest that a lot of people don't stick with these drugs.
Yeah.
They're chronic lifetime therapies. And if the drugs wear off, the weight comes back. Or if the drugs aren't taken, rather, the weight comes back. And so even in these early days of seeing how that sort of thing goes, I counsel my patients, if you don't turn it on, it doesn't do anything. It's just
That's fair.
it's
Yeah.
just in there.
Yeah, that's
Um,
fair. Yep.
and we can always call on it as a backup if needed. But if people want it out, we take it out.
Okay. I mean, that's really fair though. I was just sitting there. So that's fair. What about the new one, the Aura 6000 that I read it was should be available next year? Like, what is it?
Yeah, so I'm very happy to speak on it. I don't have personal experience with Euro 6000. It was previously developed by a company called Imthera, who have also been around for over 10 years,
Oh, okay.
and now owned by a much larger neuromodulation company called LivaNova. Um, and they just published the pivotal results of their OSPI trial,
Mm,
was the acronym, and showed that, shockingly, the results are, again, you can squint at them and there are going to be differences. And I'm sure that some surgeon in the trial may take issue with what I'm saying here, but largely it looked pretty comparable to
mm,
the other two devices out there, with some give or take. Now, the nuance or the difference in the therapy is that it's a rechargeable battery
okay.
that but the battery is implanted, so it's somewhere between these other two devices,
Okay.
just about in the same place that the Inspire implantable pulse generator is implanted, um, and the approach to stimulation is different as well. So instead of turning on and off, if you look at the cuff electrode for the device, it has this helical 6 contact array.
Okay.
And the electrode goes on a more proximal portion of the hypoglossal nerve, which is easier to surgically access, but it also includes branches of the hypoglossal nerve that could activate muscles that could ostensibly
Oh,
pull
pull it back.
the tongue back into the mouth.
Okay.
And so what can be done are two things. One is there's this argument that the tongue is what's called a muscular hydrostat, like an elephant's trunk. It doesn't change volume, it just changes shape. And so some argue that if you have the right combination of the protrusors and the retractor muscles activated, that it doesn't sort of in bulk move the tongue forward, but it sort of stiffens the tongue and maybe changes the collapsibility of the airway that way.
Oh, that's cool. Okay.
So that's one argument. And then the other thing that the device can do is that if you do have a, again, don't have personal experience, I'm told this is how it works, is that if you do have a overtly bad electrode combination where it's like, oh, we look at that, it pulls the tongue back into the mouth, and during a sleep study, yeah, airflow just goes down, not up.
Yeah.
You can turn off that electrode pair so that you aren't actually activating that combination of stimulation that is unfavorable. And so
Huh.
I'm told that you can turn off the unfavorable electrode combinations. You can keep the favorable ones, and instead of turning on off, the device cycles through these electrode combinations over the course of the night. So the tongue, instead of protruding, not protruding, is I guess better sort of wiggling, and 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 it keeps the airway open that way. Yeah.
Okay, that's really cool though. I was trying to visualize it when I saw the like what the implant thing looks like, and I was like, where does it go exactly? Okay, that's helpful. So I remember, like, it's been years. I at the Disney conference many years ago, you of course gave a talk on hypoglossal nerve stimulation, and I remember you saying that you thought it probably wasn't the whole solution, and then you talked about ansa cervicalis. Like, tell me about this.
So I think the term that I've settled on when I'm discussing hypoglossal nerve stimulation therapy with patients is that I consider it an incomplete therapy. What I
Okay.
mean by that is that you and I, right now, depending on what exactly you count and don't count, our respiratory system is extremely complicated. We're using probably on the order of about 50 to 60 different pairs of muscles if you count all the sort of extrinsic accessory respiratory muscles, et cetera, to keep the airway open. And this finely tuned concert, actually no one muscle has to work that hard to keep the airway open. In sleep, it's not so much that muscles are weak, it's that they aren't coordinating well. And so when we use the hypoglossal nerve, we are banging on this small subset of tongue muscles, trying to essentially use the tongue like a pull tab to just pull the airway forward. There are research studies that show that when hypoglossal nerve stimulation fails, it's not because we didn't open up the airspace behind the tongue. As long as your therapy is operating properly, it does that. Where it
Okay.
usually fails is in not opening up the retropalatal space, the most
Huh.
collapsible part of the airway in most people. And these therapies do that just by just sheer force of will. It's elasticity. They pull the soft palate attachments into the lateral pharyngeal sidewall forward along by elastic connections through the tongue to the sidewall of the airway up to the palate. And so to boil it down and make it probably, too reductive, when I have a conversation with the patient and they're not a candidate, I say, look, you can think of the sidewall of your airway as this really floppy rubber band, and moving your tongue is not sufficient to pull open that area behind your soft palate. And so the therapy is probably not going to work well. Um, so the idea is that if we could activate other neuromuscular targets, then perhaps we can get maybe a critical subset of muscles going that will
Mm.
sufficiently hold the airway open in, say, the third of patients who are hypoglossal nerve stimulation candidates currently, but they are non-responders to therapy, or the patients that still have some significant residual disease, or perhaps even the bigger patients who aren't therapy candidates at all right now. We could treat at all or treat better if we can start activating more muscles that affect the airway. So
Mm.
that's kind of what drives my research program. What the ansa cervicalis step is about is activating the strap muscles that are at the front of the airway that are connecting basically the chest, the sternum, to the thyroid cartilage and the hyoid bone. Those muscles are innervated by a plexus of nerves that come into the cervical spine. And it's pretty variable, but there is one constant point that innervates, in particular, the sternothyroid and part of the sternohyoid muscle that is, I don't want to say trivial, but much more reliably found in one spot in the airway. And so we've been targeting that using ultrasound and percutaneous electrodes for several years here at Vanderbilt. And what happens when you stimulate those muscles is that you don't pull airway structures forward, like
Okay.
hypoglossal nerve stimulation pulls the tongue forward. You pull them down. And so the pharynx, the
Huh.
upper airway, is this floppy tube that is suspended from the skull base. And it's kind of like an accordion. It can
Mm.
stretch in length and it can shorten as the lungs fill with air. There's this body of physiology literature that suggests that when you take in a deep breath, that it stretches the airway out along its long axis, and that probably has actually multiple effects on affecting upper airway stability. If you think of the soft palate, we keep talking about dragging it forward or pulling it forward, but that's not how the soft palate opens. The soft palate is like a class 2 lever. It's like a trap door. You pull it down towards your feet to
Oh,
open it
yeah.
and to breathe in through your nose. And that's all done by the lonely little palatopharyngeus muscle, which makes up the posterior arch of the soft palate. And that muscle runs from the midline of the soft palate down, not forward, but down towards the thyroid cartilage, and little fibers insert into the side walls of the airway and the thyroid cartilage itself. And so the argument with this anticervicalis stimulation is that if I can't fill up somebody's lungs with air with CPAP because they won't wear it, then if I stimulate these muscles, I can pull down on the airway in a different way that looks to have stabilizing effects. And so the
Huh.
data that we presented at the International Surgical Sleep Society conference last year suggests that we roughly double the effect of stimulation when we combine hypoglossal nerve stimulation with anticervicalis stimulation. Um, that's in these acute physiology studies that are done during drug-induced sleep endoscopy that comes along with
Mm.
all the caveats and asterisks that you and I were discussing earlier. But
Mm-hmm.
those point directionally towards an increased degree of airway stabilization. And so I think to some degree, this concept has sort of caught some attention on the industry side. And I
Yeah.
think people are interested in seeing if this can, you know, uh, change both the effectiveness rates of currently available therapy or whether it can allow us to reach more patients.
Well, that's would it be the same device or would you have two different devices?
Oh, Seema, that is a brilliant question for the biomechanical engineer. Um, I am not the guy who designs the device, and so there are probably many different ways to. It's going to be a very interesting time. I think in the next 5 to 10 years is what I'll say. I mean, even with
That
the
is
hype,
cool.
we've spent the whole hour talking about just all the different strategies for
Yeah.
activating just the hypoglossal nerve. Imagine once you start looking at pairs and combinations of these things. I mean, even the ansa cervicalis is only one more nerve that's affecting the airway.
Mm-hmm.
There's a whole bunch of other stuff we could go for, and then there are different strategies that suggest that perhaps what we need to look at is the central nervous system and the way that the peripheral nervous system talks to the central nervous system. So perhaps
Ooh.
there are afferents that could be targeted. There's a bunch of data from looking at the chest wall that when you're familiar as a pulmonologist with the Herring-Breuer reflex, if you
Mm-hmm.
take in a big deep breath, that feeds back to the central pattern generator of the brainstem and affects respiration. And so perhaps there may be a route with some of those sorts of things.
When you were talking about the tracheal mechanism and sort of like the finger trap, it kind of reminded me of how much even just a little bump in your BMI can reduce your FRC. And, maybe we need to kind of be mindful of that too, but not just the whole idea of, well, we know that sleep apnea gets worse with obesity, but also sort of thinking about how it directly affects our lung volumes.
Yeah, that's exactly right. I am increasingly of a mind that it's not just BMI, but really body fat distribution
Yep.
that plays a really key role in the disease process in ways that I think we don't, fully understand. I mean, there's a paper that suggests that one of the biggest determinants of sleep apnea severity in women is hip to waist ratio. So
Huh.
that, the really round belly
Mm-hmm.
relative to the waist, or the hips rather, seems to play a big role. And whether that is just, it's a mechanical effect, it's pushing up against the lungs and the airway and you're crunching up the accordion, or whether it's somehow affecting the stretch receptors of the thorax, I think the jury's still out on that. And I'm interested to see what shakes out on all that.
You know what? Every time I talk to somebody who's really, really smart, like literally every time we record one of these, I leave with like a list of things I need to look up. I just keep learning more and more from all of you smart people. So if there's something that we maybe could take away from this conversation, like if you can distill it down for me, what would it be?
Oh, wow. Something to take away.
Yeah.
Um, Listen to your patients, I think, is
Yeah.
the most important thing. If somebody is truly unhappy despite having done everything you can do with them for CPAP, there are viable alternatives these days, and patients deserve to have access to that stuff.
I love that. I think that really speaks to, I hope, where we continue to evolve as a field, right? That we really want to partner with our patients and explain to them that, sleep apnea is not a CPAP deficiency. And there's lots of ways of treating it, right? And that continued conversation, I think, right? Because things change as life goes on.
That's exactly right.
Well, thank you so much for joining us today and really helping us better understand these nuances of hypoglossal nerve stimulation and how it really has evolved since, I guess, the 80s. So we appreciate you being here today.
Absolutely. Thanks for having me. I appreciate it.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.